I'd like to welcome everybody to today's webinar on the cybersecurity of medical devices. And I will turn it over to Lisa and John to take us away.
Thank you. Let me get our screen sharing here. Okay, everybody. Thank you for joining us. My name is Lisa Bezos, and I bring with me my counterpart in this project and the brains behind it all, John Helgeson. I am the Chief Information Security Officer for Nebraska Medicine, which also includes the University of Nebraska Medical Center. And John, go ahead and introduce yourself.
Hi, I'm John Helgeson. I'm the Cybersecurity Program Manager, technology-focused career in cybersecurity specifically, a lot of digital forensics, incident response related to ransomware engagements, and also done a lot of defensive work on the MDR side and also improving security operations centers and reducing risk.
And John is really the most instrumental character in Nebraska Medicine's journey. So with that, we're going to talk, I'll give a little bit of an introduction about why this is important to us, talk about the risks, what makes a solid biomedical device security program, how can you influence the leadership to drive to change, because this is an entire enterprise operational project, not just an IT or an information security project. And then we'll really dive into our case study of what we did at Nebraska Medicine and UNMC to really, I would say, flip the narrative on how we treat biomedical devices and how we improved our security posture 1,000% by it. And then we'll have some time for some Q&A at the end. I like to put this slide up because I think that people don't really understand what the sphere of influence of biomedical devices are. It's everything. And as everything becomes smarter and smarter inside of a patient room or even behind the scenes, everything is touching a patient, interfacing automatically behind the scenes with the EMR and other systems. And now we're getting into bi-directional communication. So this is why it matters to leadership. And you have to be able to tell the story to non-technical people that there really are growing this whole bucket of biomedical devices. And this goes back many, many years ago when the biomedical device companies used to claim, our device is certified the day we manufacture it by the FDA, and we cannot change a single thing about it. Well, that all got flipped a couple years ago, probably more like 4 or 5 years ago, from the FDA, and they said, no, that's not what we're saying. We're saying that, yes, your device is certified to run on humans, but you are still responsible for ensuring that your device can be updated and can be secured. And once that kind of filtrated into the vendor space, a lot of vendors are now, we're seeing, coming back to the plate and having really good conversations with us. But your leadership has to understand that because these devices for so many years were untouchable, the amount of vulnerabilities that they have that pose a risk to your organization is huge. The FDA, like I said, came out and said, no. Now the OCR and other people are coming out and they are saying it's not an excuse. Everything must be secured and safe. And then again, the risk to patient safety and care delivery, if these systems go down, what will that do to the organization? Again, this is why these systems are everywhere. And so we really have to look at this from an organizational operational perspective and not just from an IT or technology perspective. So we're going to talk about what's our role in reducing vulnerabilities. How can we have a sustainable security roadmap program? And then how can we really understand unique risks and challenges, and how do we put compensating controls on those because you're not going to be able to fix everything. So how do we minimize our risk? And then
very good. So let's talk about some real world risks here. So there's a lot of things that make biomedical devices unique compared to servers, laptops, and the rest of the enterprise environment. These are legacy operating systems with long development life cycles. As Lisa mentioned, they might be approved by the FDA 10 years ago for patient use. The device itself is still working in a clinical setting. However, the operating system or some of the software that supports it has long been depreciated. The operating system is no longer supported. So there is limited patching and updates that can be done, limited updates to old software and hardware that the vendors aren't supporting anymore. They're developing new stuff. And there are a lot of real world breaches and near misses. I'm sure you've seen in the news, many hospitals have suffered from ransomware attacks and have been breached. I personally helped several orgs put everything back together from various states, either where infrastructure is completely destroyed down to a green space and having to transition all clinical staff to pencil and paper and then back to computers. There's just a lot of levels to that. Obviously, that does affect patient care, and it doesn't impact the business and the reputation of the org.
I guess
yes, some of the same points. I'd note that while there are limitations to what can be done, we do have to explore any of the patching that can be done, that can be automated. Oftentimes, even if they're Windows operating system devices, the vendor does have to approve the new Windows patch or to be applied, so they know that it doesn't interfere with that device. So not everything can be automated. Again, the way you do your servers, your laptops across the org. And yes, a little bit older example, but WannaCry, when that happened, it was worldwide. They were targeting imaging devices. I've personally seen some imaging devices on a subnet that were compromised by threat actors. They were an out-of-date operating system. Once those got imaged, put back in place, and going again, they were immediately compromised again. There was no fix to the vulnerability there. So you do have to look at alternative ways to limit access on the network, to limit that ability to transverse and move laterally for any threat actors. Here's a few stats on ransomware and patient care. So because it does affect all these systems across the org, even down to billing, admission, and discharge, patients do stay longer. So there is a reduced amount of care available to those patients. Obviously, when we're working off pencil and paper, it's going to be less efficient than working off a computerized patient record system. So that does affect mortality rates. And as well, it does increase patient transfers. I've seen orgs, when they're in the middle of an incident, maybe keep the critical patients, but they're transferring all new patients. They aren't accepting any new, except for really emergent cases locally. So then there's a lot of transportation costs and issues that are incurred as well.
And I kind of like to put this slide in there just because I know we're talking about the top up in the top right, the biomedical devices. But as more and more things in our organization become smart, more and more things are going to end up into this bucket of other types of devices that we have to protect as well. So we can't just think about even though this topic is biomedical devices, think about it across the spectrum: physical security, operational technology, HVAC, Internet of Things type cameras. Things like how do we open our windows and close them? All of those things are snap-on to traditional IT and makes our realm and ecosystem much more complex, but they also cannot be forgotten. So what makes a core program successful? Well, truly, it really is governance and ownership. We spent years working with hospital operations and bringing in experts that say the same thing that we've been saying over and over. This is the reality of our organization. These are the risks to what John just talked about. This will happen. It's not a matter of if, it's a matter of when. And when is you never want it to happen. Okay, so what can we do to do that? Well, there's many steps in it. The first one is, even if you go by just even the NIST cybersecurity framework, that everything starts with identify. You have to identify, catalog all of your assets, and you have to figure out what they are, what they do, who they talk to, and all of it. And I'm going to tell you that is a daunting task, but John will show you later how we were able to tackle that. And then what is the risk of this, right? Is it a device that is used very seldomly, or is it a device that we need running 24/7 on the most critically ill people? Those make the project plan and the way that we attack these things completely different. And then you have to do your risk assessment and vulnerability management continual program, not just a one-time thing. And then how do we, again, like I was saying before, what if you have a device that can't be updated, can't be patched, well, how can we protect it? Well, that's what we do with network segmentation and other controls. But then it really goes back to vendor and lifecycle management. Are we rotating out these devices on a basis that allows us to be as safe as possible? And then what are we doing to plan for the incidents in each of these areas? Not incident planning overall. I'm talking about what would the radiology department do if their 6 out of 10 of their MRI machines became completely unusable. That is also incident response and planning. We, as in the IT technical people, can come in and try to help fix the systems, but a lot more of it is people and process. So like I said, governance and ownership is key. Executive sponsorship. This is talked about. I actually have a meeting with our CEO and our COO every other week. This is the topic of conversation that I have with them, is about our biomedical security and what are we doing for our safety of the organization. We have elevated the digital safety up to the top levels in our organization, just like we have patient safety, just like we have employee safety. Digital safety is just as important and just as top of mind to our executives. I'm actually leaving after this to go down to our board of regents that run the university to have this exact same conversation about all of our risks and vulnerabilities and what are we doing about it. You have to elevate it to that highest level in order to get this sponsorship down. And then we also have to have very clear accountability. There's the clinical engineering teams. Those are the ones that make sure that the MRI machines are actually calibrated and doing what they're supposed to be doing. And then you have the IT and the InfoSec teams behind the scenes that we have to augment them. So we have to work together. And then really truly own the inventory. Our biomedical clinical engineering team, they're the ones that purchase the equipment, but they can't purchase it without telling us so that we can do all of our classifications and our risk management. And then, like I said, the real-time inventory is, I'd say, key to everything. And then how do we categorize the devices in order to profile them to know this is MRI machines, these are lab machines, these are point-of-care machines, because they, again, everything matters for, especially when you have an incident. What is the most critical to bring back up, and what does it touch, right? Bidirectional infusion pumps, big deal for everyday access, right? MRI machines can still have, if they have lost network connectivity, they can still take local MRIs, right? They just can't transfer it back to the PACS. You have to have a plan for all of that.
And that kind of flows into risk assessment and vulnerability management. You have to have some sort of live asset discovery tool that is showing you what is really on your network. If you're anything like every other org out there, as we've moved through the years, there's devices, there's servers, there's subnets, there's shadow IT that have been added on that are functioning perfectly, but no one knows anything about. There's no more documentation, so those need to be found. And then when you do find it, when you do have that live asset discovery to see what's really there, you need to run through routine assessments, finding out what's there, evaluating the vulnerabilities, evaluating how open that is to the outside, and the amount of time, energy, and staff resources that would be needed to patch and address those. Some sort of tooling to automatically cross-reference that operating system, that software version with known vulnerabilities, so you can have metrics to decide what you're going to do first, again, what you're going to prioritize, and with always the eyes on patient safety and the impact to the org. Some of the tools to do that are the FDA UDI database, the MDS2 files, which have been phased in. Initially, those were a voluntary disclosure from the medical device manufacturers, and they are now mandatory. They do disclose what the operating system is, any known cyber-related vulnerabilities, what versions of software, what versions of software in the background were used, open source software was used in the background to develop these devices, so you can account for vulnerabilities there as well. And then lastly, a device from the manufacturer. Most all of them have a walled off support or knowledge base that you do need to get registered to. They need to validate, of course. They want to make sure that you do have these devices in-house so that they're not sharing all this critical information out to the public. But it's essential to get that information, to get those MDS2 files. Many of the asset discovery tools out there will let you upload those MDS2 files. So they're machine readable. So again, that could be cross-referenced against known CVEs and give you a pick list to start. Here's how we focus on prioritization of resources. First, anything that's a life-critical device that's network connected, anything that is creating, storing, transmitting EPHI, and then anything that's a business critical device, again, that's network connected. Any regulatory data devices that contain EPHI that are maybe transmitting, and then just normal critical devices on the network related to these. Here's just an example of some of the vendors. I'm sure these are familiar, and there's a lot of competitors as well, but you can see we work with Philips, GE Healthcare, BD Alaris. I've interfaced with all these folks, and as Lisa mentioned initially, FDA has changed their guidance and is emphasizing they do need to be responsive to changes in the threat landscape and responsive to their clients and customers. So scope of our program, we deployed a medical IoT discovery tool. Again, it's doing passive discovery of everything on the network, correlating information that it is able to pick up, like perhaps the MAC addresses, to do a lookup, to match them with a vendor, or be able to fingerprint those and match them with a different pump that was seen on a different client's network. A lot of these devices are very specialized, and if you go to a generic MAC address lookup tool, you're not going to get accurate information. This is kind of the secret sauce of these asset discovery tools that are focused on the medical market, is they do contain a catalog detailed, so you do have that information instead of a list of 60% of the devices being unknown or partial information on an OS. What I've seen is reporting back that it's a Windows generic device, but it could be anything from Windows XP to 11 and or old Windows 2008 to current server versions. So once you have that information, again, then you can get some metrics to prioritize your resources. Again, as Lisa mentioned, one element of devices that are critical that you don't have a lot of options as far as patching or updating. Again, if you have a $4 million MRI that's functioning correctly, it's not necessarily in the budget to get that replaced. So you need to look at ways to isolate these devices on the network from that lateral movement from a threat actor. If they would get into one, that they wouldn't get into everything. So a lot of segmentation, VLANs, accurate profiling of those devices, and aligning zero trust principles as well. Another piece to this is part of the government's and part of the technical controls is to look at the security controls that the vendors are responsible for. Sometimes there is vendor direct support of these devices. Sometimes that's shared with the internal resources at the hospital, and sometimes that's on the hospital or some other third party that's been contracted to take care of them. So you need to be specific on who is responsible for providing updates, for giving access, and for coordinating with internal InfoSec folks as far as patching and this whole process.
Yeah, and I really can't emphasize the top one enough of working with legal and procurement to make sure that, to John's point, that the support is written in there as to what they will provide you and how quickly they will provide it to you. We have put language in that we must know within, I think it's 3 days right now, but the new HIPAA security update rule is saying that vendors must now contact us within 24 hours of knowing that there's a vulnerability in their system. So we're going back to all of our vendors now, and we're making sure that they have not Nurse Susie, who is their contact out in the organization, but for anything technical, we're going to have a standardized inbox for all of those alerts and those things to come to. So we have one centralized place instead of them going to whoever their SME is inside of either IT or in the operational world. We're going to try to focus that so that we have one centralized inbox for all of these security alerts so we can funnel them more, because as things are growing and evolving, it's going to happen more and more. But if we're being held accountable to new HIPAA security languages, we need to have a mechanism for our vendors to be held accountable as well. I guess I'll take this one, John, since I'm talking, but really it goes back to also incident response planning and business continuity. And if you don't know where your devices are, and you don't know what they connect to, and you don't know what organizational units in your hospital operations use those devices, you're going to be running around like a chicken with your head cut off when an incident happens. So really, truly understanding where all of your devices are and who is their users and into what capacity are they needed is step one. And then you need to take that information that you know, and you need to incorporate it into your tabletop exercises that you're running with not just the organization as a whole, but we actually are starting to run them with each one of our subunits. Each department is going to have their own mini tabletop that we give them the stuff to write, and then they have to fill out the information that they have to what was the most critical. If everything was down, what was the most critical thing besides our EMR to their care every day, right? That they're giving to these people. And that's going to also help you in the long term to understanding, oh, if system ABC is down, but I know from all my tabletop exercises that only these 6 units in the hospital said that that was one of their most critical ones, then I know that that's linked to them, and I can document that and put it into my business continuity system so I can understand scope much, 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 much faster. And again, that all goes back to rapid isolation and response. If we know who is affected by what, we can focus our communication to those people, and we can work on getting those people back up faster instead of trying to fix everything at once. But really, truly, we have to have actions that drive change. We need to have leadership, and I'm not talking about IT or information security leadership. I am talking about leadership across the enterprise needs to be involved in the cross-functional governance of all of these biomedical devices. We have a governance team, and it consists of people from legal, finance, hospital operations, safety, to then the IT and technical teams. It's all of those leaders in the room to understand why the decision is being made. And if decisions were being made to say, we have like John was saying, a 10-year-old MRI machine, and we know it has these vulnerabilities on it, and we know what could happen, but the organization from a financial perspective is saying, oh, can't we just defer that another year to do something else? They're not being told the whole story. Now, through our governance process that we have, we're able to elevate up the risks, the technical risks, to the organization to decide whether or not they want to take those risks on for the entire enterprise. And it's very, very interesting how the perspectives are changing. You have to have the leadership fund these tools. We have over, well, I think I just looked the other day, John, I think we're over 8,000 connected medical devices on our network. 8,000. 68,000. There is no way we could dig through logs and try to find the needle in the haystack of we have 68,000 devices connected to our network, and 8,000 of them are in this bucket. How can we profile those easier? You have to work smarter, not harder. And those discovery tools are key. I don't think we could have gotten as far as we did without them. And then your leadership has to support cybersecurity and cybersecurity program in their capital planning every year. I always tell my team, be very careful with what we ask for, because I have been in this role now for 8 years, and I have extreme support from all of the leadership that we don't usually get turned down, because I talk in this narrative. I say, you can make the decision. It's your decision as a business operations to make, but it's my responsibility as an information security officer to tell you the risks that you're taking on by choosing A or B. And so by elevating that up to being their responsibility and their ownership of accepting or mitigating the risks, it really truly has created a very, very well-funded program here at Nebraska Medicine. And again, I continuously talk about HIPAA regulations, NIST, NIST frameworks, and then Joint Commission requirements. And then now with the new HIPAA high-tech security rule changes coming out, it's going to even have more. But you have to talk in the same language all the time and use the same words with the same story, and let them make the decision as to whether or not they're going to accept the risk or if they're going to mitigate the risks. And most mature organizations, or organizations that are safety first matter, are going to then elevate up the IT and cybersecurity up. And then you need to have metrics that matter. We're going to show some metrics from our organization here in a little bit. They didn't really understand when we said we have 80,000 vulnerabilities on these 8,000 devices right now. They're like, oh, okay. And then as we showed how our program is actually driving that and taking it down, and then how we can show that we actually have less systems going down with help desk and changes or incidents because of our continuous patching and vulnerability management. It truly is taking the risks out of the devices and making them more stable, which in turn is making the hospital operations just go even better. So like I said, establish, fund, support, and then ensure compliance. If you speak these languages all the time, and again, like I said, do not change definitions, do not change your frameworks, just find out the industry standards and go for it. And you just talk like a broken record. Your leadership will understand it. Again, it took a while here for them to understand why we should care about this. Because like I said, we have 68,000 plus devices connected to our network. Over about 8,000 of them, maybe 8,500, are biomedical devices. It seems like a small thing. And so we should really care about everything else. Well, no, actually, it's this small bucket that was forgotten about by all these years that brought these risks higher and higher up. And then, like I said, metrics matter, and consistent metrics. We have to know, and again, like I said, John, in the case study here coming up, will show you what he presents to our leadership every month. And he says, this is where we're at, this is where we are, this is what we have. And these are the ones that we know are benign. And we know they're benign because they either, you can't access the MRI machine from the internet. So therefore, that vulnerability is irrelevant here. Those types of things. We go into that level and we explain to them why we're doing what we're doing. Okay, so then we're going to talk now about what we did at Nebraska Medicine. And I'm going to talk for a little bit about, again, the history of how this program came to be, how we were gifted the opportunity to bring John in to lead this, and then John's going to talk about all of the crazy work that his team did. But how did we get to where we are? And this is probably the story, if you talk about to your own institutions, this story is not unique to us. This is the pretty much exact story that I hear when I talk to my peers all around the country. It is explosive growth. In 2010, we had 32 buildings on our campus, about 16,000 devices. In 2024, we had 58 buildings and 54,000. I literally just pulled up the numbers today and we're up to 68,700 in 2025. Why? What are we doing? Why is it happening? Well, it's happening because everything's getting smart. I like to put this in there so you can explain this because not everybody understands biomedical devices, but they understand TVs. Your TV, and I'm going to age myself here, but back in the day, I was the remote control for my father who sat in his chair and he said, hey, turn the channel to one of the 3 to 4 channels that we had, right? Then came cable, right? And all of a sudden we went from 3 to 4 channels to, maybe 100 channels. And by golly, we had a remote control. And then now we're appified, right? I can watch TV from anywhere. I don't need an actual TV. I can watch these apps from my phone, from an iPad. Everything is becoming smarter. If you think about the world in that lens and then apply it to things that are happening inside of a hospital, that is why we went from the 16,000 devices to now 68,000. And then I talk about the smart pump because the smart pump is even more. It's even more than that because not only did you used to have a nurse that would put in the recipe into the pump, then we had a pump that could accept recipes and have safety guardrails around it. To now, it's bidirectional into your EMR and into your pump system, and by golly, you can remotely turn it on or off, or you can remotely increase the dosage. What risk does that do to the patient? When it was the one on the left, it was the risk of if the nurse put in the wrong recipe. The one in the middle was, did we screw up a recipe in the system, but yet we at least know that all the pumps are working with the same parameters. To now, all of a sudden, remote controls, right? So big shift in risk and big shift in, but we've also increased patient safety by being able to do this, but we've increased the risk to patient safety by not, if we don't have it protected enough. And this is kind of what John and I said at the very beginning of our tour when we came together to make this thing, this program here, is we had 7,500 devices. Now, again, like I just said, we're back up to 8,500 now. We had no dedicated IT support to handle these devices, and we had no real inventory. The biomed team knew-ish what they had, but it was really manual. And we had no automated way of knowing that a new thing came on. And we're not alone, right? This is the story from across the industry. But so what did we do? Well, this is our framework that we use for everything. And like I said, we talk about the NIST framework. That's the one on the left. You have to identify all your systems. Then you figure out how to protect them, whether it's patching, whether it's segmenting, how not. Then you have to detect whether or not there's been a breach or there's a new vulnerability. Then you respond to it, you recover, and you go on. And then now with NIST CSF 2.0, they've also added the governance around it. Everything has to be governed. And like I said before, that is the key to this whole thing. But what we really try to look at also from a Nebraska Medicine story, and like I said, consistent messaging, consistent stories, consistent ways of talking. This is my ecosystem that I talk about all the time. You have a user or a system. It uses a end user device system. Could be a biomedical device, could be an iPad, could be a computer. That connects to a network. That traffic goes into an application. That application sits in a server system cloud, and it has data behind us. Information security and IT are in every single one of those stair steppers, and information security is constantly turning the gears in between each one of these to make sure that things are safe. If you go back to the days of COVID, for instance, they talked about Swiss cheese, right? And that you put different layers of defense on, and it's only when the holes of your Swiss cheese that they penetrate through. Think about it like that, okay? Really, truly, what we're trying to do is keep our patients safe and keep the data that we are using from these systems safe and secure so that we can actually act upon them to know when our patients are needing us. All of that goes from the device all the way down. We have to make sure that the entire ecosystem is protected. So then here's John and his wisdom of his cybersecurity program he put together.
Couple quick notes on that last slide. Yes, EPHI patient data is the big target, and it's there in every step of the path. And another note on recovery. I think it's important to be able to have your backups, of course, but also be able to back up your configs, your network configs, your device configs. If you don't have that, it's going to be a day or two for a vendor to fly out and get that put back up. If you do have that in a secure, immutable, backed up, you're going to be back up in hours or half a day instead of days or weeks. All right. So a lot of this is familiar. We've talked through this. First of all is collecting all the critical data elements. In the past, again, wasn't really a focus of Biomed Service to collect the operating system, the firmware, the software version. So all that does need to be gathered, to be reconciled with these old databases, if it is there at all, along with the new asset discovery tools that have live data. So that is going to be some hands-on interactions. Not all of these devices respond to network tools or to scans. You're going to have staff, boots on the ground, hands-on keyboard, flip that into the config mode, the admin mode to collect that data, and then get it centralized in your databases. Once you have that, of course, all those correlate to the current CVEs, so you can start doing risk assessment. And of course, that ties into vulnerability management as well. You're going to need to patch what you can. And again, keep in mind time, energy, and resources, staff hours, to divvy up based on risk what you're going to focus your efforts on. Again, the overall arching consideration is risk mitigation, risk reduction. What we were tasked with there was reducing patching or addressing 90% of the life critical and business critical vulns in 90 days from when they are released. There are some caveats on that. Sometimes the vendors do take an extended period of time before they'll test and release a patch, oftentimes much longer than say Dell or HP when they're releasing patches for the laptops or servers. So do have some consideration for lag based on when the vendor is actually going to issue those patches. And then as we move forward and get that hard data of what operating system is there, we do find a bunch of obsolete operating systems. A lot of these devices maybe were never booted into the standard OS side, or it's some weird yum Linux version that, again, no one in clinical staff or IT ever sees. There's a screen to program in the IP address or the DICOM ports, and you're done. That data does need to be collected. And you will find obsolete operating systems out there. Those do need to be addressed, as mentioned earlier, in capital planning and replacement planning as you develop dealing with the risk of these devices in that manner. Again, security training is essential. Staff to work in this program come from IT, cybersecurity, or biomed backgrounds. So they do need to have adequate entry-level cybersecurity training and be able to prove that they are competent. They do need to have training on the asset discovery tools, so they do know how to use them as well. These are complicated network tooling. And if you're not careful, you can disrupt the network. You can disrupt these devices. You can disrupt patient care. You don't want to go in and slap a patch that shouldn't be there on that MRI that's $4 million and have it be down for a week while the vendor comes out to clean up the bricked firmware. You need to be very careful and deliberate on these patches that you are applying. Again, a lot of this can't be automated. And again, it does tie back, the bottom right there, to overall governance, reporting out the progress, the KPIs, reporting out what priorities you're working on, and adjusting as the org leadership gives feedback to say, no, we want you to focus on these other priorities. We've accepted that risk, or have some replacements coming in a longer term plan. So you need to refocus and use your resources wisely.
Now I'm going to inject here for a minute because this is the roadmap that John and team came up with for me. And I honestly laughed at it. I was like, there is no way from 2023 that you're going to get this far by 2024. There's just no way. But I let him go and I said, oh, ha, ha, ha. And then, boy, did they prove me wrong. Not only were they able to accomplish all of this, they were able to even go further. So I'm going to show you one of our readouts from February of 2025 this year. And so from June of 2023 to February 2025, they have resolved over 80,000 vulnerabilities that we had on our network. 80,000. And again, they're a small but mighty team. They're not an army of 50. What do you have? Four staff
folks,
down
yes.
that are dedicated to this. But now it's getting to the point where, and maybe I'm speaking too much for John, but now it's getting to the point where it's such a process now that they're not putting out fires every day. And they're actually finding that they have a lot more bandwidth to do other things now because they've created such a foundational program. So John, you can talk about your beautiful report here.
Yes, so split out according to our priorities. Again, life critical, anything that could harm patient care. Business critical, anything that could compromise the device or the ability to deliver that care by the business. And then lastly, how severe the CVSS score is. We want to concentrate on those high and critical vulnerabilities. We're not interested necessarily of going around and patching those 1.2s. Those will fall off, or they're not able to actually be exploited. They're more of a theoretical vulnerability. And I would say a lot of this is using as many force multipliers as you can, as much automation as you can to discover, to align with the other folks. Lisa mentioned earlier, align with IT, align with InfoSec, align with the clinical staff, because you're going to come in and interrupt them, or you're going to be there after hours. You need to make sure the device is functioning after it's patched. You don't want interruption to clinical care the next day. So a lot of attention to detail there, and a lot of working with those other folks across the org to get to these numbers.
And again, I cannot emphasize enough, I do not think that our program at Nebraska Medicine would be this successful without the hard work and the coordination of John and his team. I always tell people say, oh, how can we recreate this? I said, you need to clone John. But we're here to tell you all of John's brains and how he was able to put this massive project into a systematic methodology like we just showed you, and we actually made real impact. So with that, I think we're at our Q&A now. I'm going to stop sharing my screen so I can read if there's questions, or I don't know, Thomas, if you want them to come off mute to ask their questions.
Sure. We have a couple of questions here. Let's see here. The first one asks about, it's from Dustin here, asking, where does your business continuity person or department come into play with your program and assessments?
So twofold. One is I meet with them every quarter, and then their leadership is also on our governance board, for one. And then two, we are actually really coordinating really well this year about these. We've always done our tabletop exercises together, but now we're going down into, like I said, to the departments and units. And so they are forcing, the business continuity department is forcing all of the departments to really take a deep dive look at this to figure out what devices, what systems they are really truly dependent upon. So again, like I said, we're arm in arm with them, but they're also a very small and mighty team. So one of the things now that we've got our arms around, or I don't want to say we fixed the biomedical risks, but we definitely have a better understanding of them. One of the things that I'm doing for our fiscal year starts July 1. One of the things we're really doing for the next fiscal year is honing in with our business continuity teams, and also going to go back to, do we have a tool that we can do this? Do we have, how can we automate some of the things for them? How can we do better at asset tracking from an IT systems perspective back to departments so that we understand these things? Again, going back to the identify, track your assets, figure out what's critical and what's not critical, and then have the business continuity teams help with the plans for each unit.
Okay. Other question here is from Michael. It says, simply wanted to express our collective appreciation to John and Lisa for sharing their insights and experience. Is there a healthcare association of CISOs, CISOs, or others to network and partner with before an event?
So if you're not a member of the Healthcare ISAC, I highly recommend you do that. That is a collection of many of us. Also, there is, I participate in several collective groups, things like I go to conferences. I'm also on a bunch of panels with people. So really, truly, my network is just kind of organically morphed. But we also have I work really closely with the other CISOs in Omaha specifically, but we are welcome to having conversations with anybody. So if you would like to create a consortium or even just have a conversation, you can reach out to the Region 7 group here and they can get you in touch with me. That's part of my role in this fun little project we're in, is that I'm happy to help coordinate or get you in touch with people that can help you with issues. But you're correct. Knowing I call them the friends, knowing your friends. When we had an incident in 2020, after we figured out the who and the what, didn't know how yet, but when we figured out the who and the what, I instantly got in touch with my regional CISOs to tell them what we found so that we could make sure that they knew what to look for so we could stop at theirs. And we actually have, I don't think I can actually say it, but we had like about 3 institutions that were able to put blocks in for some indicators of compromise that we found, and we're able to stop the same attack from happening at their organization. Again, because we have this network of people. So happy to expand that, happy to do more.
I'd add on to that. Yes, the HISAC is a very valuable resource. I'd also call out InfraGard. It's a FBI public-private organization that helps protect critical infrastructure, and healthcare, of course, is among those. And there's also some local regional CERT groups if you start to get really specialized in cybersecurity. But again, to echo Lisa's resources as well.
Yeah, I know there's also through some of the various fusion centers, there's cybersecurity specific groups within those that I would encourage folks to get in touch with. The fusion centers are going to be run by your states, so those are going to be very specific to wherever anyone's from. So I don't want to point to one or the other just necessarily, but they also have a lot of different resources there as well.
Yeah, the one thing I would say, and I'm not just trying to say we're special because we're special, but we are special. Some of those groups too, if they're general focus for cybersecurity, so say you're a manufacturing plant, their focus is just going to be way different than healthcare too. And so sometimes, especially if you're newer to some of those groups, sometimes you feel out of place because they just don't understand and other organizations that I would say have unlimited pocketbooks too, they don't understand what it means to have 10-year-old MRI machines on campus. Just upgrade it, right? So we have a lot of woes and a lot of feelings, but you're not alone. That's the point, is that you're not alone, and you shouldn't start from scratch on any of this. Reach out to us, and we can even, if we don't know the answer, we'll find some people to get in touch with you, or we can even have more of these top conversations.
Okay, definitely. There's lots of resources to go out and get. We just gotta. Sounds like mostly like anything else. You want to be at the table. You want to go find your table. You want to be at the table. Make those connections definitely before you have an event. It's going to help out in a lot of things. I'll put out a last call here. Those were the questions that we had. I know there was also a question in there about whether or not this would be available to share. I will remind folks that this recording will be available in the next couple of days. You'll get an email about when that recording is up and ready to go, so that if you have other folks who couldn't make it today but would like to also have this information, that will be a possibility. I don't see any other questions at this point in time, but so I definitely thank Lisa and John for coming on and talking about this topic that I saw 80,000 things being or issues being addressed, and that blows my mind. So definitely a busy group of folks and a problem that seems to only be growing. So glad to share this information with everyone. Appreciate you two coming on and sharing this with everyone and appreciate everybody coming today.